All right, now switching gears to mantle cell lymphoma. There are two studies which will talk about the transplant indications, or rather, is it even beneficial? I remember from our conversation from treatment algorithm, Pallavi, you stated for mantle cell lymphoma, you've not used transplant for past 5 years. Now, talking about our triangle study. So if you could please briefly talk about the study design and what have we learned from ASH 2024 from this?
So I think it basically reiterates what the original presentation had shown is that if you add a BTK inhibitor in induction and probably more importantly in maintenance phase, then you can really get away without doing a transplant. And then if you want to be even doubly sure if your patient would have benefited from a transplant or not, the other study that was presented in ASH was, I think, EA4181, showed that if your patient achieves MRD negativity after induction, then for sure there's no room for transplant. So I think both these data sets are almost like a death knell for transplant in mantle cell lymphoma. And I think most of the treating physicians are very happy with that because we are very comfortable with doing induction and then using BTK inhibitors. Transplant was one of those things which was logistically challenging with a lot of side effects for patients. And as I think we've talked about before, we would replace the BTK inhibitor from Ibrutinib to one of the second generation BTK inhibitors just because of a better side effect profile in these patients.
Right, just to
Absolutely.
reiterate that, especially with the study involving ibrutinib, at least in my practice, we have replaced that with acalabrutinib or zanubrutinib because ibrutinib has fallen out of favor because of the side effect profile. Rahul, have you done the same in your setting?
Yeah, and we're so used to using a or Zanu even in CLL, so it's easier to use that right across for all our patients, be it mantle cell or CLL. Okay,
One more
so
thing I would like
sorry, go
to
ahead.
add, which is kind of related to this data, is that there was another presentation in the triangle study. Some countries mandated rituximab maintenance based on the Lima study, which had shown an overall survival benefit. In some countries, it was not approved, so they just got the BTK inhibitor for maintenance. They did show that rituximab maintenance is important even with Ibrutinib. So don't skimp on the rituximab maintenance just because you're giving
Right.
Ibrutinib or another BTK inhibitor for the maintenance portion.
And Pallavi, before I move on to the next study, you had touched on MRD in community settings. Is MRD something that I need to rely on to make treatment decisions, or is it still very much part of a clinical trial settings?
I don't do it. So that gives you the answer. Like it's still part of clinical trial setting. Also because, like clonoSEQ is CLIA approved for B-cell malignancies, but you might have a hard time getting it paid by payers because it is only genuinely approved for CLL and not for other B-cell malignancies. I don't think it's ready for prime time yet.